arrival because Russ has worked with Jacob before and I thought he would introduce him. But I don't see Russ and I don't want to cancel the seminar because Russ didn't show up. So I'll introduce Jacob. So Jacob Jaremko, you can see, will be talking to us about this topic. And I want to say something in advance of that. So Jacob is both an MD and a PhD, MD and PhD from the University of Calgary, and the PhD from Biomedical Engineering. Right? And so now he's an associate professor in the Department of Diagnostic Imaging in the Faculty of Medicine and Dentistry here at the University of Alberta. And so he's been one of the people who has been most passionate about the development and application of artificial intelligence in the medical domain. And what we're trying to do with Amy is we're trying to diversify to say that we need more people to engage with across the boundaries. Here you will, for those of you who don't know, we often talk about the 87th Street gap, that the medical faculty is on the south side of it and the science faculty is on the north side of it. So we're trying to change those things. One way we change them, strangely enough, computer scientist me is the academic lead for the precision health signature area. That means working a lot across back and forth over 87th Avenue. And what we'll see over the next month or so is some presentations from the medical side on the other side of 87th Avenue who are demonstrating how artificial intelligence can provide value to the challenge problems that they see there. So with that said, I'll let Jacob tell us about what he's doing.
Great.
Thank you.
Thank you very much. It's great to be here. A bit short notice, and I'm really happy to be able to come. So I'm going to talk today about artificial intelligence to automate ultrasound medical image analysis in particular. And I'd like to convince you that that could be the 21st century stethoscope. So because most of you don't know me, I'll just start with my background briefly, and then we'll look at comparing AI in 1999 when I first got involved, and 2019. Look at medical imaging modalities, talk about specifically the example of hip dysplasia, which I've been working on for a long time, and we'll touch on some data issues, data privacy and liability concerns, which are pretty important in artificial intelligence in medicine. And I want to just give you an idea of what my vision is for how we can all work together. So, to start with my background, I have strong Alberta roots. I was born in Calgary. My grandparents are a bit further north, sort of in the Elk Point, Rosebud area. My undergraduate training was in Calgary as a civil engineer. So I did structural design and highway design. And this was back in the day when assignments were done on graph paper by hand. So there is a design for a little truss structure. Then I did my PhD in Biomedical Engineering, and I'll talk a bit about that because it was related to, it used neural networks, an earlier version of neural networks. And I was relating surface and spine deformity in scoliosis. So I'll tell you a bit more about that. My clinical training has been quite extensive. I went to medical school in the University of Calgary. My radiology residency was here in Edmonton. And then I went away for 2 subspecialty clinical fellowships. One was in Melbourne, where I learned to become a pediatric radiologist. And then I studied Musculoskeletal Radiology at MGH in Boston. So I then came back to Edmonton and I'm a holder currently of the Alberta Health Services Endowed Chair in Diagnostic Imaging, which runs for about another year. And I'm an associate professor in radiology, also a partner in Medical Imaging Consultants, which is Edmonton's biggest radiology partnership. And I'm co-founder of a startup company, which I'll tell you a little bit about during this talk as well. So I wear several hats. So that's me, and as you can see, I have a mix of clinical and computer science type background. My interest in artificial intelligence began in 1999 when I was doing my PhD, and this was back in the day of the Y2K crisis. People's cell phones had numeric keypads. Things were different back then. And to show you how deep learning worked in 1999, I'll just show you what my PhD thesis was about. So our goal was to try and predict the 3D shape of the spine from the 3D shape of the surface of these patients, teenagers with scoliosis. So scoliosis is a curve of the spine. Most people's spine is straight up and down when you look at them from the front, but if you have scoliosis, for unknown reasons, your spine curves. And And so you can see the shape on the surface, and underneath it, there's a 3D shape of the spinal curvature. The reason that it's important is because if this curve progresses, then a patient's lungs can collapse and people can, in severe cases, can die of it. So, but in many cases, it's not that severe, so we'd rather not be doing full spinal X-rays on these patients, and there was a high radiation dose with that. We wanted to see if we could just look at the surface shape and predict what the spine looked like beneath. So my study design was to take the surface shape, which we'd scan with a laser scanner, and try and derive some numbers related to that, and try to predict from that what the shape of the spine was underneath. And we compared linear regression and neural networks. Linear regression, you basically take indices or numbers or measurements that come from the torso. You set up, a few of these indices, and you make a linear combination of these indices to predict the output, normal or dysplastic, or the actual Cobb angle, which is the angle of the curve. So it's a simple design, but it only works. It only takes linear combinations of input indices. So then we moved to neural networks, which are able to assess nonlinear combinations of inputs. And so back then, this was a fully connected network, and it had sort of 15 to 30 nodes in the first layer. It's 10 nodes in the second layer. We experimented with adding 3 or 4 hidden layers. We had a few bias nodes. I wrote all of this manually in the MATLAB Neural Network Toolbox, MATLAB version 4 on my laptop. Did some programming in C++ because the MATLAB was very slow analysis. And so neural networks back then, it was kind of like a slightly fancier version of linear regression. So I used to explain it that way, that we were doing slightly fancier regression. And back then, because of the limited capabilities of the computers, what we did is we took inputs was a series of numbers, and the most important question for my thesis was how to decide which inputs to put into the network. So we had this complex mass of data, like you had this whole 3D shape of the torso, and then you have to narrow that down to a few indices that are useful for the network to predict from. And so I set up a genetic algorithm where I computed the fitness of various of these 47 indices I worked with by running trial neural networks on it to try and pick up the best combination of these. So of my 3 years of thesis work, about 1.5 years of it were spent sorting through all these indices to get down to the point where I could run the final neural network. And I put this picture up here because that is when the pterodactyls were roaming the earth, because things have come a long way in neural networks since then. Right? So the outputs were numbers, and in fact we just had two kinds of outputs. One was the actual angle of the curve, and the other was like a diagnostic binary or categorical output. And so also we had a very small data set. There was only 115 patients, but we still produced a result where the neural network was 30% better than the linear regression. So that's back then. And so the neural network was already, that was kind of the first era of neural networks becoming useful. Right around then was when they were starting to be, people started to see, oh, this is neat, this actually does help. So we fast forward to 2019, and the key difference is that the neural network is strong enough, as most of you know, to read the whole image. So you can just dump the entire image into the system in a convolutional neural network, and people have figured out how to make non-fully connected layers and have convolutional kernels churning through the input data to sort through it and simplify it down and come out with, at the end, you can actually output an image, right? A modified image, a mask over the image, or change to the image, replace a horse with a zebra, this kind of thing, right? So you can either output numbers like the old-fashioned way, or you can actually output an image where you've identified a structure or highlighted pathology, something like that. So, I mean, that's spectacular. That's what I love about working with people in computer science and engineering on these projects, because the advances have come so quickly. If I was to go and redo my thesis in 2019, then I would take, a convolutional network. I would directly input the 3D shape of the torso, and then I would, the work that I spent manually a 1.5 years doing, I would have the convolutional layers of the network do for me, extracting key features. The only problem is I wouldn't necessarily know what those key features were. It's a bit of a black box, right? So, we could be developing techniques to interrogate what does the output look like in a middle layer and see if we can figure out what the network thinks are the key features. And then at the end, I might be predicting the actual 3D shape, with some other intermediate layer structures, or I could use a fully connected set of layers at the end, basically bolt on the old-fashioned network to run my original strategy. The whole thing would probably take, 6 months. So I think it would be a much different task nowadays. So that's all very interesting from an academic point of view, but why, as a clinician, do I care about this, and why should we all care about this? My job as a radiologist is to interpret images and make diagnoses. So what is it that I do? Well, I distill complex image data into a text report containing the findings, diagnosis, and plan. So this funneling or distilling function, where I take image data and come out with a simplified sort of key features, that's exactly what the neural network is doing, right? So this is very disruptive for radiologists, pathologists, and many other branches of medicine. But I argue disruptive in a good way. So already software is coming out, AI software to assist radiologists. Here's one of the first ones to be approved by the US Food and Drug Administration, Osteo Detect. And that's a pretty neat one. You scan in your X-ray, and it reads the JPEG X-ray image, and compares it to its database that it's been taught on. And it either says there's no fracture detected of the distal radius, or there is one, and it draws a little box around the area where the kernels detected a fracture. So now at this point, that doesn't replace the radiologist, but it does get the radiologist. A wise radiologist would look carefully at that area because the computer is almost always right. So many similar products are rapidly emerging in different fields. And it's a very exciting time because it can improve the quality and consistency of imaging reports, and it can change the speed and the cost with which these studies are all done. So, so that's an example like X-ray. I'm going to show you now something about the medical imaging modalities, because different types of pictures that we take as radiologists are quite variable, and you should understand a bit about that. So first, X-rays. These are easily available in any hospital or clinic. They have very high spatial resolution. The pictures are very, very fine detail. They're good for showing anatomy or obvious disease. Limitations are that because it's a single image of the whole body, all the soft tissue structures are overlapping, so it's hard to sort out what's going on in an X-ray. And there's a lot of stuff you can't see in an X-ray. And there's also a radiation dose because it's using X-rays. So there's ionizing radiation, which has some risks for different body structures. The hardware for X-rays is, some of the systems are built into rooms, but some of the systems, a portable one looks kind of like this. So it's, one of these might cost you $200,000. A system that's in a room might be $750,000 or $1 million. The portable one would weigh 1,000 pounds. So you can't just, it's pretty hard to move these things around. They're the size of, at best, they're kind of the size of a refrigerator. So they are kind of portable, but they're still quite expensive, as you can see. And there's limitations to what you can see with X-rays. Now, CT scans, or computed tomography, is basically using the same underlying technology as an X-ray. It takes images using shooting photons through the body, but it's done in a circular fashion, so the photons are emitted going in a beam and detector array that's spinning around the patient. And so what you can do with that is you can reconstruct it to take apart the overlap that you have with the X-ray, and then you can see everything inside. And so it's a fast whole body scan. A CT scan of the entire body can take 20 seconds now. You can just, some of you have probably had CT scans, so you just lie on the bed and you just get whistled through. In fact, nowadays we scan, as a pediatric radiologist, we scan babies, and there's a flash CT scanner now, which is so fast that you actually have to tell the nurse to stand back because they will get hurt because it just bangs through. It takes, 3 seconds to scan the baby's chest. There's kind of a moment of inertia there. It's quite striking. So the problem,
A question about the CT scan. So the stroke ambulances are using those flash scanners in the ambulance?
Yeah, they have portable scanners, which are a bit smaller than this one.
Yeah.
And they are limited in that they're also, the bore has to be quite a bit smaller, but it's big enough to see the head.
Yeah.
Right? So you can get, so it's true, I should have put that out there. There are portable CT scanners that are more like in the ballpark of this size.
Yeah, okay.
It costs lots more, but they're kind of like more like that size. And then you can do body parts, like you could do the head, or you could do the arm or knee. Yep, absolutely. So these are very expensive toys. The CT scanner is $2 million and up. The portable one's probably still $1 million and very fancy technology. You know, the weight of that one is over 4,000 pounds. You have to shield the room. It's like, you know, if you're going to put in a CT scanner, you need to talk to an engineering firm. But they're very powerful machines, and modern medicine just wouldn't function without CT scanners. MRI is sort of we sometimes joke that it's the answering machine. So there are no more answering machines on phones, but there's an answering machine in medicine, and it's the MRI. So you can see all the soft tissues. You can see everything in different levels of contrast. There's no radiation, but there are problems. It's actually very grainy pictures. The spatial resolution is quite low. Looks okay on this picture, but each of these pixels might be only half a millimeter in size. That's 10 times bigger than an X-ray pixel. And lots of people can't have an MRI. Like, for example, yesterday in clinic, I reported about 30 MRIs, and 3 patients could not have it because they were claustrophobic. Put them in the magnet. You go into this tunnel, and it makes noise and jackhammers and pounding, and people just can't tolerate it. So it's also a long test. It might take half an hour to do a scan, so motion is a problem, and there can be reactions to contrast. And of course, the main problem is the availability. It's a very expensive test. The machines are at least $3 million, 10,000 pounds. You need to have a supercooled, superconducting magnet in the system. It's just very expensive to build an MRI. So it's not something we can put in every clinic and every street corner. Ultrasound is quite different than all these modalities, and that's why I like ultrasound. It's very high resolution. It's at least 10 times as small pixels as MRI. It's a dynamic real-time test, so it takes pictures like video. Like I can put an ultrasound probe on the arm and squeeze the tendons, and I can watch the tendons moving and see how smoothly they're moving. I can see pathology like that. It's soft tissue detail, and there's no radiation. There are several problems with MRI, with ultrasound though. It's very dependent on user training, and you can't see really deep inside, especially if people are big. And very importantly, images are confusing. We'll talk about that more in a minute. But just recognize though that the key advantage that ultrasound has is that this stuff is super cheap. Compared to all those other modalities, you can buy a probe for $5,000. There's one called the Butterfly, which you can buy for $2,000 US. That particular one, the quality is not really there yet, but you can see in that range, a few $1,000s, you can have a machine that looks inside the body. And they're handheld. You can just, you can attach it to your smartphone, and there are some that are out there that are actually completely self-contained and just send a wireless signal. So it's completely different than other medical imaging modalities because it's handheld. So, and inexpensive. You could put one of these anywhere. Anywhere there are people, you could have an ultrasound. So what's different between MRI and ultrasound? Well, ultrasound is much higher resolution, user-dependent, but it's non-intuitive. This is an example of the resolution. So this is the tendon of the shoulder rotator cuff here, the supraspinatus tendon. On MRI, you get about 5 pixels. On ultrasound, you get about 50 pixels. You can see it in great detail. So it's just it's zooming in. It's a panoramic lens versus the zoom lens. But the problem is, with an MRI, you can scan the whole body. On an ultrasound, you're holding a probe, waving it around. It's kind of like you're painting the body. So you're moving, you as the person holding the probe are putting the probe in certain different spots, and you're kind of like looking like with a flashlight at certain bits of the body, trying to put it together. So artificial intelligence can help us to understand what's coming from the ultrasound. The rules of ultrasound are not intuitive. So everything, all the other types, the X-ray, CT, and MRI, are all electromagnetic radiation. So using photons, basically, of one form or another. Well, in X-ray and CT, and then MRI is still the magnetic side of electromagnetic radiation. So the rules are kind of the same. But on ultrasound, it's sound waves, and things that you don't think are going to look the same. This is a gallbladder on MRI, and there's a stone in it. On the ultrasound, the sound waves penetrate the fluid really well, but they stop at the stone and they bounce off, which gives you a reflection like this, and there's a shadow. You can't see anything behind the shadow. So all of this behind here is artifact because the beam is stopped there. But right next to the gallbladder is also gas in the duodenum, or the small bowel, and that also blocks the sound waves and produces bright shadows that reflect that look remarkably similar. So this is not something the other imaging modalities have a problem with, but it's confusing if you're looking at this and you don't know what you're doing. Having been trained in ultrasound specifically, is that the images look kind of like other images, but have different rules. So when you put all that together, what you have is a pretty obvious opportunity, I think. There's the opportunity to bring handheld ultrasound technology, the gadgets, the hardware can be brought into the point of care anywhere. You could have it in the ambulance, you could have it on airplanes, you could have it on at clinics, you could put ultrasounds everywhere, like defibrillators. And here's the picture of one of these little defibrillators. But, and then the concept there is we could bring the tertiary expertise, the expertise that comes from the big hospitals and the universities, can bring it right to the patient in that handheld machine if artificial intelligence is driving the interpretation of the images from it. So that's like the stethoscope. So it's a handheld tool that can be used by a physician or a medical person to understand what's going on inside the body. It's much more powerful than a stethoscope because you can actually see with it. So I think ultrasound is unique that way. Because of all these problems here, other people are not investigating ultrasound the way they are CT, MRI, and X-ray. It's a lot harder to do it. It's a tougher technical challenge to make artificial intelligence deep learning networks that understand ultrasound than the other kinds. But we've been working on this for several years, and I'm going to show you the first use case or first foray into it that we've been working on so that you get a feel for how it works. So, hip dysplasia. So this is another medical condition. DDH stands for developmental dysplasia of the hip. And what it means is you have an abnormally shaped hip bone. So on the left here, on this side, patient's left, is the normal hip. So the acetabulum, or the pelvic bone, is strong enough and oriented enough that when the patient stands up, the load from the ground is transmitted to the bone. So it's stable. But if you have one of these acetabuli where it's really shallow, it's vertically oriented, it's rounded, then what happens is that same load just causes the femur to roll up the side. So it's unstable. Okay, and so it's a mechanical problem, and it's due to congenital or developmental anomaly that gives you a hip that's shaped wrong. And when you have this so unstable, it obviously leads to early arthritis and damage to the joint. So this happens commonly in infants who are breech. It's much more common in girls than boys. And it's often in the left hip, and that has to relate to the position of the uterus. And it leads quickly to osteoarthritis. So a number of, this is a very busy slide, way too many numbers. Just a couple things to highlight, is that hip dysplasia is common. So about 1 in 100 people will have had at birth a hip that was a bit loose. Probably some people in this room would either have it or know of people who have hip dysplasia. And about 1 in 1,000 people has a hip that's actually dislocated at birth. And when you run a bunch of numbers, what we come up with is that every day in Alberta, about 4 children are born with hip dysplasia. And because we don't screen for it routinely and don't treat it as well as I think we should, we end up with 2 hip replacement surgeries done for the arthritis caused by hip dysplasia every day. So there's obviously a 30 or 40 year time lag in between being born with it and getting the surgery, but it's this identifies that there is a real clinical need to investigate hip dysplasia, which is what made me interested in pursuing it. So when we're screening for hip dysplasia, what happens is, any of you who have children, you will have seen, the pediatrician will check the baby's hips to see if they're loose or not. Okay, but that exam is obviously not very sensitive if it's a mild case or if the pediatrician doesn't really know what they're looking for. X-rays are not that useful because the femoral heads aren't even bone yet until they're 6 months old. The ultrasound, the pictures look like this, so it's difficult to interpret. And an Austrian guy named Graf invented a classification system, but as you can see, it's a little bit complicated too. And there's lots of errors in that. So many limitations using conventional ultrasound. I've just taken some pictures of people performing the scan. If you happen to move the probe a little bit, you can generate pictures that look
almost whatever shape of the acetabulum we want. The key measurement is this angle, and that angle, you can, depending on how you hold the probe, you can make that angle look normal or dysplastic, just depending where you put the probe. And only, as you can see here, only small changes in the probe position, relatively just a few degrees. So it's kind of tricky to do that scan. So we've been doing 3D ultrasound for a while now. We have a commercial probe that we do a mechanical sweep. It produces kind of a video of the hip. And here's an example of what it looks like. Here's a dysplastic hip. It's very round. The normal hip is more of a sharp edge to it. And we can produce some models from it. So we were doing, before deep learning came along, we were doing processing of these 3D models in a way that's probably familiar to some of you, where we just manually label, we draw points on the curve here, draw some points on this, and it generates a model interpolating the slices together. And then from that, we do some calculations, make some angles on the best fit planes, make some normal vectors, make some radius of curvature, just calculate a bunch of numbers based on the shape that we generate. And we can use that to determine whether the hip is normal or dysplastic. And so again, before deep learning, we did this study here. We had 1,700 hips over a 5-year period, and we found out that by using this 3D ultrasound approach where we calculated those numbers that I just showed you, we were able to reduce the borderline cases by 3/4. So we made it a more confident test. We made it a more efficient clinical test. So that's all great, but it still requires a lot of expertise. What we thought, once artificial intelligence was becoming, once CNNs became kind of something we were aware of, we thought, well, can we automate this with artificial intelligence? All we're doing really is pretty simple. We're finding 2 points on the femoral head, and we're finding some points on the line to identify this really bright line. That doesn't seem like something that's too hard for a computer to do. Right? You think, well, surely we can find this bright line. Right? And so that's what I then focused on working on. So we needed access to large data sets, like thousands of patients to do this. And we went through several iterations. I started with one grad student, and we did a proof of concept, and that was okay. Then we hired a tech and had 2 grad students, and we developed this software that could do it. But it was incredibly buggy. Every time Amazon updated their server with the tiniest update, our entire system crashed. It was just a disaster. We had to go reprogram it for like a week, and the moment that the tiniest upgrade. And it was driving us all crazy. So we learned from that experience that we needed expertise in artificial intelligence, neural network architecture, and training. We needed someone who knew about web software development. We needed to make sure that our clinical strategic direction was just right. And we also realized that there was a role for doing this in a way that was more robust, like commercializable. The strategies we were using with the neural networks, I think it's worth mentioning these. We had 2 different ideas. One is to do a shape analysis. So kind of like the scoliosis, what I was proposing in 2019, we start with this image, put it into the network, and then if you use inverse graphics network type of design, then you could get out from it the 3D shape directly. So that's one approach, and you can get the 3D shape of the acetabulum segmented from this. The other approach is an end-to-end design, where you go and at the end you just get a tick box, it's normal or not. So those are kind of the 2 main competing strategies, and we continue to play with both of those strategies right now. And I'll show you, just for fun, what the results of our early networks were. So we're trying to find this bright line. Right. Yeah?
So you have 2 approaches. But the practitioners, did they express which one they prefer?
Well, so it depends on the practitioner, actually. So we've been dealing with stakeholders on that. And if you're a neonatologist, if you're just checking the babies at screening, you don't really care about anything except this, right? So if it's normal, great. If it's dysplastic, you just say now it goes to surgery. It goes off to get treated. Kind of, right?
You may want to have some kind of explanation in the first one. Please use some kind of.
Right. So I personally prefer this, and so does the surgeon. So for example, we work with Dr. Delay, who's an orthopedic surgeon at the university, and she strongly prefers that top version because then you can see how dysplastic, and there are many interesting questions like, we have the 3D shape, some people do better on therapy, on treatment than others. Well, can we decide who's more likely to succeed? What's the prognosis, right? So I think there's a lot more information with that first approach. Like, this would be sort of a very basic version, but like, really, it's not adequate. You really need, in my opinion, most people looking at it would like at least some idea of what's going on with the shape. And I think, and certainly anybody who's actually managing the condition wants to have more. So, but there is kind of a role for that basic screening function.
That means you can have them work in pair.
Yes.
Work together.
Yeah, exactly. So it's complementary kind of, isn't it? So, yeah. So we're keeping both strategies. They're both. I think it's valuable to program both. So. So here we are, we're trying to do this bright line. So initially we were a little oversensitive, to say the least. And then we refined that, but we overshot the mark here, and then we were not sensitive enough. So we're great at picking up this, but we missed the area of the most interest there. So, then we had to fiddle with that, and we finally figured out a way to actually get the bright line properly. And then this dark part, the femoral head, is trickier because it's kind of a black area outlined by bright stuff, so it's not as easy to capture. But we've got an algorithm now that works for that. So now we're pretty happy with this. We can actually identify these two structures and get the 3D shapes fully automatically. And the first time that these guys, who I work with, showed me that, I was just fantastic. Here we are, right? Finally, we're there. So Meadow.ai is a medtech startup company that I'm one of the co-founders of. The main person driving this is Dornoosh. She was my postdoctoral fellow for 3 years while we were working on this, and then she saw opportunity here and split it off into a startup which is working on developing, commercializing this particular application. So I'm very proud of how that's gone, and it's I think a nice example of how you can go from a research academic feasibility study to something that is actually potentially